This is all normal uptake. And here's uncinate process. See how much uptake there is there? You don't want to think that that's tumor. That's actually normal uptake in these scans. As I mentioned earlier, typically we see a lot of uptake on the well-differentiated or usually grade 1 and grade 2, sometimes grade 3 for these NET spots or DetectNet, the dotatate PET-CT scans. When we move into the poorly differentiated tumors, oftentimes we see more uptake on that FDG PET-CT and less on dotatate. This is that patient we saw earlier, if you guys remember back a couple minutes ago. This is our MRI. This patient got a dotatate PET-CT scan. What do you guys think? I'm going to make an argument to you that you can see the lesions quite well on the dotatate PET-CT scan. They correlate. And that lesion in the pancreatic tail, while I know all of you in the audience here are very astute and fantastic diagnosticians, it lights up. It's really pretty easy to see here on the PET-CT. So it's something that really, for those of us that really like to see things light up and be, really transparent, it's becoming a game changer for us and for our ability to detect these lesions. So gallium-68 dotatate, which is what we were doing at Utah, we've now moved to copper-64, which is usually cyclotron produced. The gallium-68 dotatate generator produced most frequently. When we do this imaging, we usually do delay sandostatin just before they have their imaging. And it can have a profound effect in patient management. In about 60% of patients, it's felt to change management and affects a major change in their treatment and what will happen in about a quarter of these patients. Many studies have shown improved sensitivity and lesion detection compared to indium-111 Octria scan or I-123 MIBG. I suspect that even the ones that didn't show improved sensitivity, there's some reason for that. It's pretty profound, the difference with PET-CT. So our ability to detect these lesions has gone up remarkably, and it's really been a game changer. So I'm going to just show you some examples here. This is same patient, had gallium-68 dotatate PET-CT versus Octria scan. So Octria scans that indium-111 study that was done, and was done not long ago. I mean, we're talking about 10 years ago at our university, that's what was done. So this has changed dramatically. What do you guys think? You see more here or here? You can nod, you can just say yes, I see more here, and I suspect if I do, you guys probably do too. You can see all these lesions here. I mean, the image is just so much more defined than this side. And this is what's happening in our ability to detect these lesions in these patients. This is a different sort of comparison of indium-111 Octria scan versus the NET spotter, the gallium-68 dotatate PET-CT. What do you guys think of the liver on the left, so this side? There's some spots, you can see it. You have to really squint, but they're there. So, and oftentimes when we're looking at the unfused speck as well, and you might be able to see it. How about here? On this side, which is our PET-CT, you can see all these lesions. They're really popping out at us. So this is, again, where our detectability is just so much better. I know many of you guys are looking at contrast-enhanced CTs. You look at CTs quite frequently. So do we. It's very, very important. This is the same patient. This is the contrast-enhanced CT, coronal, over here. And this is our gallium-68 dotatate PET-CT. You guys see the lesions here? They're there. You may. As we've discussed, I know many of you guys have fantastic vision. How about here? And here? I'm going to venture, and this is just my guess, that you guys can see it better. And I'm venturing that too just because I do, so I'm assuming that it kind of matches. This, again, is just what's happening with the field. We're able to detect so much more with the PET-CT than what we were used to. So dotatate PET-CT scan is really make a profound difference for diagnosis, for staging, for management decisions, whether the patient will go to surgery, whether they're going to go to embolization, whether they're going to have Lutathera or lutetium-177 dotatate. It can change management. and it's been a profound player in the management of these patients. As we go further, when we kind of touched upon it a little bit, there's a degree that people feel the uptake and which PET-CT agent is used may make a difference in understanding whether these tumors are de-differentiating, so moving from well-differentiated to poorly differentiated, and actually assessing response to treatment. Touched upon this yesterday. We're going to touch upon it again because this is an important thing for neuroendocrine tumors, which is PRRT, or peptide receptor radionuclide therapy. It's lutetium-177 dotatate. It's used to treat gastroenteropancreatic neuroendocrine tumors, or GEP-NETs. It's also used to treat others too, but this is with the FDA approval. Lutetium emits high-energy electrons, beta and gamma, so we're able to image these patients with SPECT, and we're also able to treat them with that beta emission. The peptide targets SSTR with high banding, particularly of SSTR2. This was the NETTER-1 trial. It's definitely worthwhile for those of you that are considering moving this into Egypt and into your practices. This trial was a clinical trial, phase 3, that really showed dramatic responses in these patients. So here you can see the progression-free survival and really a profound difference between those patients that received lutetium-177 dotatate versus standard of care. Now remember, this is standard of care. This isn't that they got nothing. This is standard of care. So really a profound difference for these patients. And in overall survival, we saw also improvement, and it was, at the final analysis was about a year difference. That didn't reach statistical significance. A lot of people feel that's because these patients, some of the patients that were receiving the standard of care were crossed over in the trial. They actually ultimately got Lutathera. So even with that, there was quite a difference. So this is just our comparison of a patient, and I showed this particular slide yesterday of a patient that we feel is a good candidate for the therapy. They had really intense uptake on their gallium-68 dotatate PET-CT, or their NET spot, compared to the FDG PET-CT, where you really don't see the same sort of uptake. So this is one that likely that therapy is going to go to these tumors. It's going to make a difference. Same thing here. You can see this very, very large mass with intense uptake on the dotatate PET-CT. This is the mass here. It really doesn't have that same uptake. This is a patient that's likely going to respond well to the treatment. This is the opposite. So in this case, we have the FDG on the top, and you can see these tumors with intense uptake on FDG and really very, very little uptake on the dotatate PET-CT. This patient is likely a poorly differentiated neuroendocrine tumor. They're likely not going to do well with the treatment. This is something that we're doing now at Utah. We've started to do the copper-64 dotatate PET-CT, and there can be real debate between these two. They're both really fantastic agents. The detectability or sensitivity of the copper-64 dotatate does seem to be better. For a lot of the neuroendocrine tumor patients, their tumors are slow growing, and how that will impact the patient, there is some difference between them. But this, you can see that the number of tumors that we're able to detect with the copper-64 dotatate, generally speaking, can be much, much better. This is underway in terms of investigation. This is sort of, as time goes on, I suspect that this will be in our treatment options for these patients is alpha therapies. Alpha therapies are currently underway in clinical trial, and some of the anecdotal, like this patient, have shown profound responses. Oftentimes when we treat these patients, we will see them have great responses in terms of their symptoms are better and their tumors are not growing as fast, but those tumors oftentimes don't melt away. So the follow-up imaging, we often still see the tumors. With the alpha therapies, some of them, it's almost like the tumors appear to melt away. So this patient had just profound disease in their liver in particular, and you can see after they received their actinium-225 dotatate, over time, many of those tumors disappeared. We may see that in the future, at least for some patients. So things are very, very promising and bright for this field and for our ability to treat patients suffering from this disease. So when it comes to nuclear medicine and neuroendocrine tumors, nuclear medicine is playing an essential role. And I think we're going to see an increasingly essential role. The oncologists that treat these diseases know their neuroendocrine or know their nuclear medicine and radiologists quite well.